It is so great to see so many people I know that have joined the webinar and many folks that I don't know. As we wait to filter individuals in, I'd like to get started because many of you are here for this incredible webinar and the panelists. So let's dive on in. Today we're talking about the launch of the Community Eye Health Journal in the latest issue, Up Close and Visible, Correcting Global Presbyopia. I am Abby Steinberg, the executive director at Livelihood Impact Fund of the Eyeglasses Initiative, which has been operational for the last 3+ years. And I want to talk a little bit about the global magnitude of eye healthcare. Many of you already know this, that over about a quarter of our planet has an eye health issue and growing, about 2.2 billion people. About a billion people need access to glasses and are visually impaired. Please continue. And when we look at the issue a little further, we realize that of the individuals with refractive error, about 80% of the issue is presbyopia. And that's actually why the Eyeglasses Initiative got started. We looked at this incredible problem and we said, wait, about 800 million folks just need access to near vision spectacles or reading glasses, which cost under 50 cents to manufacture. So what is presbyopia? It's the natural aging of the eye where the lens becomes less flexible and you're less able to see up close, which impacts many different vocations, from tailoring to factory workers to even farmers. Many people overlook farming as well. Most people who are affected are above 40 years old, but we are seeing people in their late 30s have earlier onset of presbyopia, especially in closer to the equator. And the way it's addressed is simply just with a simple pair of reading glasses, essentially magnifiers. And glasses, as many of you know, are about 700 years old. Next, please. So when we look at this problem, 2.2 billion have a visual impairment, about 1.8 are presbyopic, and about 800 million have limited access to eyeglasses, mostly in low and middle income countries. And for us that live in North America, most of Europe, parts of Australia, we said, wait, why is this an issue? Many countries made it over the counter 40 or 50 years ago. So when you go through pharmacies, clothing shops, supermarkets, airports, you find them everywhere. And individuals easily self-select them. They just quickly try them on, look at something, their phone, or look at something up close, and they say, that works, that doesn't work, and can simply walk out with a pair of readers without a prescription or without additional barriers to access. But that is not the case. So most Africans and Asians don't have access to reading glasses simply over the counter. And many folks don't realize that reading glasses aren't just for reading. They're really cutting across many different vocations. And one thing we've been amazed to see is that maybe you might think, oh, wait, cocoa pods are quite big. Why would someone whose near vision is impaired need to see a cocoa pod? But if you're hand pollinating, if you're trying to sort, if you're trying to sort and process cocoa more effectively, if you're trying to do any type of accounting or manage the end to end from, farm to market, there's many near vision tasks that can improve your access to market and your income. And when we talked to more farmers, they said, well, I've only noticed once the pests have really eaten or killed our crops. Aphids are very small, and if you can't see them up close, they could destroy your crops. We also talked to tailors and seamstresses who said, it slows my work. And another thing that's been interesting is that people can't load credit on their phone or repay pay-as-you-go solar loans on time because they're waiting for someone younger to come home and input more credit on their phone. So the more we've been looking into it across vocations and quality of life, we've been seeing it cut across. And what's great is there's incredible research that's coming out around increase in productivity, the negative implications of with not having reading glasses. We're seeing more workers across textile, more income across textile workers, increases in annual income, even for cataracts patients who have reading glasses after. And it's estimated that we lose 50 billion plus in economic losses every year. Next, please. So here's a little bit about our work at Livelihood Impact Fund. We seek, we work to meaningfully and durably improve the lives of the global poor with an emphasis on focusing on Africa in general as a foundation. The initiative itself is focusing on this 800-person challenge. How do we enable access to eyeglasses at the last mile for individuals in need? And you can learn a little bit more about our work and our comprehensive research on our LinkedIn, our newsletter, and here's our email. And just a little bit about our work over the last 3 years through partners, through remarkable partners. Some of you are on this call. We've had the pleasure of working across almost 19 countries with about 60 different types of distribution. And really what we're trying to understand is what is the most cost-effective way to get glasses from a factory to a face, bundling it and ensuring sustainability and last mile access. We both work with private sector partners and public sector partners to ensure continuity of care. We want individuals to be able to both get it from their community health worker, their primary care facility, their pharmacy. We also want people to get it through religious institutions and the local corner shop to ensure access. All of our programs have comprehensive referrals. So individuals are screened for presbyopia, but also referred through the health system. And many of our programs, which is quite exciting, we're seeing upwards of 90% of folks turn up for referrals, which is something many doctors here that I work with in the US could say they don't see that level of show-ups for referral. We've been able to reach over 3 million individuals and distributing almost 3 million pairs of glasses and hope to push well beyond that threshold this year. And so it is my pleasure to introduce this new issue of the journal, and my sincere thanks to the London School of Hygiene and Tropical Medicine and the many impressive authors that contributed. I know it took a lot of time and effort. You please scan this QR code. We'll share it throughout, including a link. This issue highlights not only the scale of global presbyopia, but also promising and very practical solutions already underway, and the opportunity to address it at scale over the next decade. This is really solvable, and very much solvable, I think, in a decade, and definitely in this lifetime. And I look forward to discussing more. Before I hand it over to Andrew, I'd love to introduce him. He is our trusty moderator today. Professor Andrew Bastawrous is an award-winning global eye health leader and doctor who wears many, many hats, too many hats, and I keep adding some others. He's a professor in global eye health at the London School of Hygiene and Tropical Medicine and founder and CEO of Peak Vision, a social enterprise transforming access to eye care worldwide. He is also a TED Fellow and a recipient of an OBE for his service to eye healthcare. Andrew's work has reached over 10 million people and helps shape how eye care is delivered across low and middle income countries. Over to you, Andrew. Thank you.
Thank you, everyone, for joining. This is a photo of Kiasi, who features on the front of the Community Eye Health Journal. She's a farmer in Zimbabwe, and she lost her livelihood as a farmer simply because of uncorrected presbyopia. Her story is one that has been told for many decades, one of avoidable vision loss, but we have overlooked near vision for most of our collective history. And here's a little look at why. In 1972, a WHO study group established categories of vision impairment and blindness in order to facilitate the collection of population-based data in a uniform format. At that time, the prevalence of vision impairment was calculated based on best corrected visual acuity, which means people were tested with optimal spectacles or a pinhole for distance vision. The cutoff for categorizing vision impairment at the time was primarily based around blindness, which meant that the person could not see the top letter of the chart at 3 meters away with the best available correction. And in 1975, it was estimated there were around 28 million people blind. At that point, the global population was around 3.8 billion, so less than half of it is today. By 1990, the standard definitions were contributing to building a global picture, as well as a worrying trend. And that trend, driven by a growing and aging population, indicated that the number of blind people in the world would double by the year 2020. This data led to a joint initiative led by the World Health Organization and the IAPB called Vision 2020. And the intention of Vision 2020 was to eliminate avoidable blindness by the year 2020. And the initiative did reduce global blindness, but not as fast as the problem was growing. Going back a little bit to the year 2010, at that point in time, reforecasts were made, and the forward-looking projection continued to show expected population aging and growth driving increasing global blindness. However, the definition at that time evolved from just being distance level blindness to distance level vision impairment. And you can see as the threshold was lowered, the number of people who were defined as vision impaired at the current point in time and into the future grew. Before 2010, eyesight was always measured in these surveys as best corrected vision. Now, this means it was measuring how well someone could see with the best possible glasses or lenses. And the problem was many people didn't actually have these glasses or the right prescription. So the methodology missed a lot of people with real world vision problems. Soon after that, the system switched to measuring presenting vision, which means how well a person could see with what they showed up with. So whether they owned glasses or not, or whether they had glasses that were underpowered. And this mattered because it gave a more realistic picture of vision in the real world and helped people with needs, helped us really understand the needs at a more holistic level. By the year 2020, so our near most recent data, we showed that there were 43 million people in the world blind and 295 vision impaired. But when we looked at the driving causes for that, they were primarily uncorrected refractive error and uncorrected cataract. And just prior to this 2020 data being released, the WHO released the landmark World Report on Vision. Keeping in mind to this point, everything had been distance vision impairment. The World Report on Vision did some really important things. One, it shifted the focus away from blindness to functional vision loss. And one of the ways it did this was incorporate this new definition of mild distance vision impairment, the highlighted light blue there. And this is the kind of level at which people's driving legal vision is impacted. Crucially, it also, for the first time, brought in an emphasis on near vision impairment, so the ability to see at a threshold close up. And we can see at this point, this category ends up being the most by number of any category within the vision impairment group. And that collectively adds up to the 1.1 billion that we talk about today. And so you can see uncorrected presbyopia is a huge driver of that, and critically will continue to be as populations age and grow going forward. And so if we are going to reverse this curve, near vision correction has to be a core part of the agenda. And as much as the data tells us this is a growing problem, we also know that behind every one of these data points is a person and their person's story, like Kiasi, whose picture is featured there. You can see the immediate impact accessing a pair of reading glasses had for her. And it meant she was able to go back straight into farming and regain her livelihood.
Deixa eu estou com a giranda aí, ficou. Está o giranda aí. Eu já não vou ter dor, já dá bom. Não vou dar aquilo, não. Não vou chegar, não vou chegar. Agora se tem a giranda tem de saber.
So hopefully the audio all worked that time, and it's my pleasure to welcome all of you now to the next part of this webinar. So good morning, good afternoon, good evening, if you're here live or if you're watching this on the recording. It's fantastic to see such a global audience here. And we're here today to launch an important new issue in the Community Eye Health Journal, which is focusing on correcting global presbyopia. And as we've seen, this is a condition that affects nearly everyone over the age of 40 and remains one of the most under-addressed challenges in global eye health. So today's conversation is really about a simple and powerful question. If we already have the solution, what is stopping us from reaching everyone who needs it? I'm delighted to be joined by an exceptional panel who will be joining us in a moment, who are going to bring perspectives from global policy, clinical care, health systems, and frontline implementation. So just before they come in, let me introduce the four panelists. First, we've got Stuart Keel, who is Technical Officer at the World Health Organization, who's leading the global work on vision and eye care. And I've been fortunate to work with Stuart for many years as he and his team have really built momentum around eye health and vision within the WHO and globally. Stuart brings a critical global perspective on how presbyopia fits within universal health coverage and WHO's vision targets. Stuart will be followed by Priya Morjaria, Assistant Professor here at ICEH at the London School of Hygiene and Tropical Medicine and Head of Global Programme Development at Peak Vision. I've known Priya and worked with Priya for over 15 years, and she's a rare talent and vital voice in this space. She's a public health optometrist, combining both clinical insight with large-scale program design, particularly around innovative delivery models. Priya is also joined by Thulasiraj Ravilla, who is the Director of Operations at Aravind Eye Care System. Tulsi has been a personal inspiration of mine for many years, who always seems to find time to share learning and guidance and is always a few minutes away from an email being responded to on a tricky question. Tulsi is one of the world's leading eye health system leaders and has decades of experience scaling high quality, equitable services. And then our final panelist is Oteri Okolo, who is the National Eye Health Coordinator for Nigeria. I've had the pleasure of working with Oteri both as a teacher on the master's course and now as a partner in eye health work in Nigeria. Oteri is both an ophthalmologist, a national program leader, a fearless activist, and she oversees eye health in the most populous country in Africa with real experience of scaling access through public systems. So this is a rare opportunity to have a combination of perspectives in one conversation. So I'll welcome the four panelists to the stage. Great, lovely to see you. And as the others join, where the way this is going to work, so each of the panelists here have authored one of the articles in the recent Community Eye Health Journal issue. And so each of our panelists will be briefly asked to share the key messages from their article in the journal, which I'm sure you're going to go and read in depth after this. And so the order will be Stuart, followed by Priya, followed by Tulsi, followed by Okolo. And the question to each of you is, what is your article about and why does it matter now? So Stuart Keel, if I could hand over to you to kick us off.
Yeah, thank you very much, Andrew. Good morning, good afternoon, everybody. I'm going to share a couple of slides just to provide the key messages. So, Andrew, you can see that okay?
Yeah, nice and clear. Thank you.
Very good, very good. So, as Andrew mentioned before, through the World Report on Vision published in 2019, really the WHO internally and externally really raised the profile of this issue of near vision impairment and presbyopia specifically. So I'm just going to give you a very brief introduction now to relevant WHO targets, tools and initiatives that are particularly relevant to this topic area. And I think no better place to start than the very first target for refractive error that was endorsed at the 2021 World Health Assembly. And this was quite an ambitious target of a 40 percentage point increase in effective refractive error coverage by 2030. And The reason why this target is important is because it doesn't just focus on increasing access, but also on quality of care to make sure that people are actually not only getting access, but they're getting the access they need to stop them from having a vision impairment or connect them to the care that they need. So when we were going through the process of establishing this target, it was very clear that given the well-established impact of near vision impairment on quality of life and productivity that you heard from Abby earlier, spectacle coverage for both distance refractive error and near vision impairment due to presbyopia were important to consider in this target and reporting on this target. So the WHO is supporting countries to achieve this global target through what we call the SPECS 2030 initiative that was launched together with a large group of the sector partners a few years ago. And we're very pleased to see so far that the demand for this initiative has been quite strong. 29 governments already and growing have committed to national or subnational initiatives and really raising the profile of particularly public sector integration of eye care services, but refractive error services in particular. I've just highlighted here on the screen some of the key country level actions that the SPECS initiative is focusing on within countries. And that includes things like legislation for provision of eyeglasses within the government sector, adopting minimum quality standards for both distance and near vision spectacles, integrating screening and provision of near vision spectacles in primary and community levels. And I know some of the other speakers will be going into more detail on specific examples of this, addressing trade barriers and implementing public health campaigns to address misconceptions around presbyopia, near vision loss, but also driving demand for eye care services as well. So I wanted to highlight now a couple of tools that are relevant that WHO has developed recently in collaboration with experts that are relevant to the topic area of near vision impairment. And the first one is the Vision and Eye Screening Implementation Handbook. So this provides step-by-step guidance for conducting both near and distance vision screening and also eye screenings within community and primary care settings. It includes evidence-based protocols for screening and includes standard record, referral, and follow-up forms. And it also includes practical information around the requirements for personnel, equipment, supplies, amongst others. So very useful, practical tool for countries and stakeholders when planning for evidence-based screening programs in different populations. And this ranges not only from older adults, but also newborn school-age children as well. To really translate this more into practical action on the ground, WHO, together with the WHO Academy, recently published also a series of primary eye care training resources, really targeting primary health workers to identify, manage, and refer common eye and vision problems. So this is delivered as a blended course, open access, plus a few hours online and in-person skills and workshop. There are 3 modules, but the module that's particularly relevant here is a module on primary eye screening and also dispensing of ready-made spectacles. So this all can be accessed via the WHO website. Very briefly now, 2 other tools or resources that are relevant, which is the minimum standards of care for minimum standards, of quality for spectacles, which really simplifies existing standards on ready-made eyeglasses, making it easier for countries in procurement decisions. And we've also been working very closely with UNICEF on a procurement catalogue as well that includes ready-made eyeglasses that has standardised specifications and pricing that's actually available for all stakeholders, including governments, UN agencies, NGOs as well. And lastly, an upcoming document is a guidance document to really address some of the policy-related issues when it comes to refractive error care within countries, really providing a number of key policy actions, identifying what are the challenges for each of these actions, and also what are the policy activities that could be implemented within countries to address some of these issues. So really a lot of information, but just wanted to provide you with a brief overview of relevant tools that may be relevant for you all. They all are available on the WHO webpage and happy to answer any questions later. Thanks a lot. Back over to you, Andrew.
Thanks very much, Stuart. So that sets the global perspective and stage for this. Next, we're going to ask Priya to come in and build on that, particularly in terms of how this work translates into delivery on the ground. And whilst Priya's talking, I do welcome anyone to ask questions in the online tool, which we will look to very soon. So over to you, Priya.
Thanks, Andrew. Hi, everyone, and I'm so glad to see so many familiar names on the webinar. So I'll quickly go into some of the key points that we've written in this article, and just want to acknowledge that it wasn't just myself. So the co-authors on this were Kovin, that's probably familiar to a lot of you in the call, Shadrach Muma from Kenya, and Meho, a refractive error advisor to Fred Hollows. And some of the points that we want to highlight and build upon from what Andrew raised is that we know there's a huge inequity. 86% of uncorrected refractive error is in low-income settings, and predominantly a lot of that is presbyopia, and it can have major impact on economics and the social equity as well. But we also know that we talk about this, we all know that near vision glasses could solve a majority of the problem. So some of the things that we focused on in the article was to say that why does this really matter? And this has real consequences because it's not just for vision, but it's for livelihoods. And we know that this simple intervention could significantly improve productivity. And so we are saying that, over-the-counter access is scalable, it's fast, and it's practical. And we've, thought about this in terms of what the WHO is advocating and what Stuart just said about, community access and community distribution and over-the-counter availability for near vision glasses without a prescription. But what I also want to acknowledge and not sort of walk away from and say very clearly is that we know that there are concerns about this. And they're legitimate concerns about missed pathology, about quality, and also about bypassing professional care. And so this real tension that exists is something that we've tried to address in this article. And what we want to say is that it's not an argument for either or. We firmly believe that over-the-counter provision could be seen as a complementary pathway and not a substitute for professional care. It can expand access rapidly, it can normalize the use of glasses, and we believe that it could actually increase engagement with eye care services over time. And then more importantly, it will allow for eye care professionals to focus on the more complex and higher risk conditions that they're trained to address. And so this article predominantly identifies how this could be possible, but we also say that if we want to address presbyopia globally, we need solutions that will matter, that are to match the scale of the problem. And over-the-counter near vision glasses are probably one of the simplest tools that we have to do that. And so the question is not whether it should exist, but how do we implement it in a way that expands access, maintains quality, and also addresses all the concerns that we have about the safety of the use of them.
Thanks so much, Priya. Really, really great to getting some good audience reaction to that. So we'll pick up on that further. Priya, going from Priya to Tulsi, who many of you know Aravind as a kind of global leading eye care organization, and you've been involved for many years doing this at scale. So we're really keen to know what have you learned and what should we learn, and what came across in your article.
Thank you, Andrew. So my article was about this concern about do other channels of distribution cannibalize the viability of vision centers. So I wanted to really address that from my perspective. Vision centers have demonstrated the potential for providing universal eye health, very much along the lines of integrated people-centered eye care. In countries in Asia where the population is dense, a vision center typically covers about 100,000 population. And in these vision centers, the refractive error correction is the prominent service in the sense that's a service where the patient who comes in actually goes back with the problem solved, and that constitutes a significant proportion of those coming to those vision centers, which also means that the refractive errors is a significant source of revenue or financial viability for the vision centers. And this is the context in which this concern is being raised. So if you look at the potential, 100,000 people covered by a vision center would most likely have about 35,000 people, roughly a third of them with refractive errors. And then if you assume that they would replace the glasses very, very conservative, let's say once in 5 years, then it would be around 7,000 glasses to be sold. And in reality, what happens in the vision center is the number of glasses sold are a very small fraction of that total potential. Typically, less than 1,000 glasses would be sold in a year. So this actually reflects in many of the community surveys. In one of the surveys that we did in a very, very well-served district, where no one needs to travel for more than 4 or 5 kilometers, the coverage for presbyopia is about 15%. And for distance, it's a little higher at 35%. So the real challenge here is around market maturity. The market has got a long way to grow. And then the wisdom is that market matures when it is driven by commoditization. In the sense, we can't keep refractive error correction up in the pedestal as a very specialized service. We have to bring it down as a commodity. And then it's got to be also supported by intense competition. All these things tend to grow the market. It has got to become very standardized, affordable. All of them will kind of lead to higher adoption. So the other avenues of selling the glasses over the counter or door to door, community workers, etc., like Priya said, hugely complement the effort. And we have to really recognize that we can't solve this problem of near vision correction to 1 billion people through a single channel. So we need to be very welcoming of all the others as co-players and not as competitors.
Brilliant. Thank you, Tulsi, so much there that we'll definitely pick back up on. Great reflections. So last but not least, Dr. Okolo Oteri, who is the National Eye Care Coordinator in Nigeria, and therefore you do have a national perspective, and it'd be great to hear from you, what was the core question of your article and your reflections on it.
Thank you very much, Andrew. My article focused on integrating presbyopia services into community and primary healthcare services. So we already know that presbyopia is a common cause of vision loss impacting productivity and well-being. And but for health workers especially, it's not just a productivity or well-being issue. It's a safety issue for both for themselves and for their patients, because they carry out a lot of clinical services at near, and they need safety and they need clear vision to be able to carry this out. Now, for a majority of people with presbyopia, a simple, inexpensive, ready-made reading glasses are actually sufficient. And we have learned this, even in implementing a presbyopia program in Nigeria. So knowing that access is not universal, and over the years, presbyopia services have basically been delivered in secondary and tertiary facilities and eye clinics, all concentrated in urban centers, city centers. We realized that we needed to rethink creating access to spectacles in non-traditional ways. Therefore, on the back of presidential political will and commitment, we designed a program using the community health and primary health care gateways, to increase access across 16 states in Nigeria. And now, if you think about it, most of us know that community health care workers, primary health care workers, are trusted members of the communities, and they can be trained to screen, provide education, and dispense these near vision glasses on the spot. Now, from our experience implementing just over a year, we've been able to train these primary healthcare workers because, like I said, screening for presbyopia is technically very simple. We have used the national guidelines, which were domesticated from the WHO primary eye care package. And for us, it has been useful. We've trained over 2,200 primary healthcare workers. We've activated over 800 primary healthcare centers across 16 states, and we've been able to screen over 1.5 million Nigerians. We've been able to provide over 1.4 million spectacles to Nigeria. And I think the important thing to note in our implementation is the fact that the first user rate was over 65%. That means without relying on the normal traditional pathways, would not have addressed this problem. And even in dispensing, we realized that we dispensed over 94% of the donated glasses. That shows us that this ready-made spectacles are, bridging a significant gap at the community level where people need these services the most and where they need near vision correction to be able to increase productivity, improve their well-being. Just to make a point about safety, in the worst case scenario, near vision spectacles will only cause discomfort. It doesn't have, other difficult or complicated clinical scenario. Now, just in conclusion, I just want to say that vertical hospital-based models have not worked for us in Nigeria. And I doubt if it has worked globally. If it had worked globally, we'll be talking about the fact that we have reached so number of people and we will still have a gap. Now that we know that these vertical approaches do not solve the problem, we need to begin to think about other ways, like Nigeria has done, a horizontal approach involving community healthcare workers who address these problems at the level of the community from house to house, that integrated patient-centered care model where they reach the patients in their homes, provide screening, and refer to centers where primary healthcare workers can easily do this very simple tests or screening for presbyopia spectacles, provide community members with the spectacles that they need, and then we will be well on our way to achieve universal health coverage for vision. So this is just a story of Nigeria's success, and we're learning, lessons every day based on our implementation to improve what we are doing, and we're hoping that this will serve as an example for countries who want to address presbyopia at scale. Thank you, Andrew.
Great, thank you, Terry. Wow, so we heard some great things there, and I do encourage you to take time afterwards to read the articles that are very thoughtful and dig into this deeper. We've got some really good questions already coming in, so please do keep asking them. We'll try and take as many as we can and try and overlap them with some of the other questions that we have for the panel. So I've got just a couple of questions to ask the panel. So if you feel able to respond, please do. What came across in a number of these things and what we hear is this tension that was articulated almost between the ideal comprehensive approach versus over-the-counter, less regulated or not regulated, and that has different opinions on it. And what I hear here is there isn't a one-size-fits-all, but how do we strike this right balance between access and quality? If anyone would like to take that.
Thanks, Andrew. I'll start with that one. And I think these concerns are absolutely valid, and so they should be taken seriously. And there are concerns around safety, the correct use of the quality of the glasses, and also the referral pathways. And so the key point here is that all of these are manageable. These are not unmanageable concerns. They can all be managed, and it's just how they're done And as you said, no one size is going to fit. The solution's not going to fit everyone. But I think there are some things that can be done. And the thing is around, allowing for inclusion of, quality checks, basic standards and regulations. That could be the first thing, the quality of the glasses that are coming. And then the question around, is there missed pathology, referrals, all these concerns. And I think over-the-counter glasses should not exist in isolation. They should be linked with clear messaging and referral pathways. And so people know when to seek further care. And then the appropriate use by, having simple education points, and Dr. Oteri, mentioned this. It's just, if you can have simple education messages that can be at the point of sale, they can go a long way for people to help them to understand, when these reading glasses are not sufficient, what do they do? How do they access further care? And so those are kind of the very simple ways to do this, but it doesn't, take away from the concerns that are raised. And so to my Optom colleagues that are on the call, I'd certainly say be involved in the training, be involved in the decisions that are being made, because over-the-counter sales has always been there. It's not going to go away. What the call now is, let's do it in a way that's systematic. And that's what I think we should focus on.
Thanks, Priya. And Tulsi, it looked like you had something to come in on.
Yeah. So this has been an ongoing kind of a concern with one group almost saying that you shouldn't do dispensing of glasses because that is not a comprehensive approach. But I would like to flip it around to say that on the positive side, you are now having another channel through which you can push the agenda of comprehensive care. No, in the absence of this, there is nothing. No, so I think these are two, because we combine both, I think we get very confused. One is helping the person who's seeking to see better close up, solve the problem. Then you have this opportunity of working with those channels, which is much more easier and practical because they are visible channels. You know who they are, the supermarkets, like Priya said, messaging, all of that becomes possible. So if we can look at it as an opportunity and not as substandard service, I think we'll make tremendous progress.
Thanks. Tulsi, I'm going to take away that quote as well. In the absence of this, there is nothing. I think it's quite helpful framing in terms of how we might come to this with a different mindset. Another one of the questions is around the role of community and primary health workers. So there's a growing global movement around non-professional healthcare workers now and community health volunteers who've become community health promoters or community health workers, and they're doing amazing work around the world. What's the untapped potential here when it comes to near vision glasses and this working at scale?
Andrew, I'll just jump in here. Now, for me, I haven't implemented this program for over a year. I consider that involving community healthcare workers and primary healthcare workers in the distribution of glasses and increasing access to spectacles is really an untapped potential, right? Because for us in Nigeria, we have found out that this vital source of, should I say, manpower, they're a vital link between unserved populations and the healthcare system. Like someone also mentioned, these are people who we traditionally will not come to secondary and tertiary facilities. And then community healthcare workers are trusted members of the population. In their communities, they are well known. They've delivered all the babies, immunized all the babies, treated them when they had diarrhea. They even have adults in the community that they had treated over the years. So basically, these people are they are well trusted, and the community can easily overcome their fear of hospital or believe in losing their sight or other cultural, misconceptions that they have around spectacles by, receiving health education from the community healthcare workers, which we have found has worked tremendously in implementation of our program in Nigeria. So you can see we have a first user rate of up 65%. So that's very important. Then also because the community healthcare care workers actually work in the community, they can engage in what we call proactive case finding. So they know the members of the community very well. They know artisans and or school teachers, or even primary healthcare workers like themselves, or community healthcare workers like themselves who struggle with near vision. They can then do the screenings in homes and actually refer the patients back to the primary healthcare centers if they cannot provide the spectacles on the spot. Now, beyond that, it's not just about handing spectacles alone. So for us in Nigeria, we're using this model to drive access to primary eye care as a whole. So we're training them to distinguish between simple presbyopia and more complex refractive error problems, and also other eye care, eye health, should I say, symptoms. And then they can then refer problems like glaucoma, cataracts to the next level of care where patients can access, care. So basically, we are opening up the eye health sector to increase uptake of services and overall reduce the burden of blindness and vision loss in Nigeria. Now, how does this actually strengthen eye health sector? Now, like I said just now, it increases uptake for eye care services. It normalizes eye care services. So people don't think about cataracts or presbyopia as something that's inevitable and, they probably will not have solutions to them. These primary healthcare workers can actually point members of the opportunity to where they can, members of the community to where they can access care. Beyond that, it helps in system integration. So basically, we are building a new eye health infrastructure at the level of the primary healthcare centers and in communities where originally eye care services didn't even exist at all. And that's really very powerful for us in Nigeria, where 70% of the population actually reside in these communities. And then at the same time, they are more at risk of vision loss. Now, it's also very cost effective, for instance. So we're using an existing network or a network of existing community healthcare workers, primary healthcare workers, which is significantly cheaper to do than setting up new secondary or tertiary facilities to address this problem, because of course in Nigeria we have to, confront the reality of a skewed distribution and even shortage of healthcare workers. So even those that are available are most likely in the urban centers and the city centers, but then leaving then those in the community without care. So these people are a very significant, aspect of linking everyone in the community, to care. So this has been a very important, initiative for Nigeria. It's been a very important learning point, and we're hoping to even scale up further. Now, for instance, I'll just tell the story of Katsina State, where we trained some primary healthcare workers. Like in all states, we didn't train every single primary healthcare worker, but by the time that state saw the value in training primary healthcare workers to scale up primary eye care, they have gone further than what we made provision for in the initiative to train an additional, potentially by the end of this year, 600 primary healthcare workers to be able to deliver eye care services, including, very importantly, presbyopia correction. So we can see that this level of workers, that they remain an untapped potential, which I believe across our countries, across our communities, if we can really tap into it, will open up eye care services to all members of the public, and then we will be able to reach our target of universal health coverage to eye care. Thank you, Andrew.
Thanks, Oteri. Stuart, can I come to you on the question of what data do we need? How should we be using data to drive the global agenda forward?
Yeah, thank you so much, Andrew. I think it's good. We've seen today, I think, that there are some quite big figures out there when it comes to presbyopia that can be useful for advocacy. However, what we also see at the global level is good quality data on presbyopia and eyeglasses coverage is actually quite limited and outdated. And this has got to do with the point that you mentioned earlier, that really it hasn't come on the global agenda until the last more recent years. So while we have relatively good data for distance effective refractive error coverage from about 80 countries, I think the comparison for near effective refractive error coverage is about 8 countries. So at the moment, we're unable to actually utilize this data to report on the global targets. And this is a shame, and it's a shame for a couple of reasons, in that we've seen the importance of this data in really driving driving eye health on the global health agenda with the data on effective refractive error coverage for distance that was launched at a World Health Assembly event. It's then got picked up at WHO in broader monitoring frameworks for universal health coverage. So really raising the profile of distance effective refractive error coverage at the global level. And this then rolls on to country level reporting as well. So I'd like to hope that we can move forward in increasing our investment in collecting population level data on near effective refractive error coverage and also presbyopia prevalence, so we can raise the profile in a similar way, but also so we can see, without this data, we can't actually see whether the actions we're taking are actually producing the impact that we want. So that would be my point, is that I think a greater investment in collecting this type of data, there's lots of cost-effective opportunities to do so, is very important for us in the future to really track progress.
Great. Thanks, Stuart. And just to note, the latest iteration of the rapid assessment of avoidable blindness now includes near vision assessment as well as a market assessment of who's been accessing glasses. Tulsi, I'd like to come to you. You said a few really important things in your comments around market maturity, the need to grow the market and competition, and that we can't keep it on this professional pedestal. Many of us in this webinar sit on that professional pedestal. As someone who operates within a very large system that influences beyond your own system, are there any kind of key things that as a collective audience we need to be thinking about?
Yes, I think we fundamentally will need to change how we think about this problem, because it's a problem that is not rare. It is literally 1 in 3 persons requires refractive error correction overall. Probably 1 in 4 requires near vision correction. So this really has to be available very, very close to them. So that's where this notion of commoditizing it becomes necessary. Today, this over-the-counter sales continues to be still in very large urban cities, where you would find this. So still, it's not really practical to solve the problem. So we really have to be thinking very innovatively about this. Like, for instance, one of our alumni who practice in the rural areas. In India, there are these coffee tea shops where people congregate in the mornings to just, like a community, spend about half an hour or so, and the stall keeper would keep newspapers to attract people for business. So this alumni of ours went and placed reading glasses of sort of varying powers, recognizing people there. Then they started using it, and then they wanted to get one of their own. And so I think we just need to think very differently about this problem. If you want to, usually bigger the problem, simpler the solution. So we really will need to learn not to complicate it.
Thank you, Tulsi. Stuart, did you want to come in on?
Yeah, I was just going to say, just building on Tulsi's, the importance of innovative models, I think, is something that we've recognised also at WHO. And one of the key partnerships that we set up under the SPECS initiative was with the Universal Postal Union, recognising that the postal services are sort of trusted providers within communities, and in particularly underserved rural communities as well, to try to get access to these populations. And we're happy now to be working with India Post in a state within India to sort of actually trial this and evaluate this model of care. Really promising signs early, and we're looking forward to sort of to evaluating this well, and then also scaling up throughout other states in India as we move on.
That's great. Very, very exciting. So, panelists, I'm going to come to you in a moment. So I'm going to just give you a moment to percolate. I'm going to ask you a question which you're going to need to answer in 30 seconds because our time is coming to an end. If there was one action our audience could take, whether they sit in government or an organisation or academia, what could they do in the next 12 months that would increase access to near vision correction. So just one thing, and you can't take more than 30 seconds. So whilst you're thinking about that, I just want to very briefly address some of the comments that were in the Q&A, and thanks for those who've already been responded to, and we'll pick up those that we haven't had a chance to. One is I want to pick up on the question of sustainability. Should they be free? Should they be paid for? The answer is yes, as in it can be both and it can be either. There's a lot of interesting research at the moment in terms of the role of a free pair being useful to catalyze the market. So we heard Tulsi talk a lot about creating a market. So can it get people into the first pair so that they realize the value, and then if there is access and it's affordable, they'll go and buy future pairs. And Livelihood Impact Fund have done some really interesting research with us at Peak and at ICEH on this. So happy to share more in terms of once people do access their first pair free, they are much more likely to go on to buy subsequent pairs. Another question around whether we see this in isolation or separate. And again, I think the answer is yes, it can be both. But we do see that it has a role in terms of presbyopia screening and distribution at increasing the uptake of other eye care services. So for example, if somebody's doing household level screening and is identifying people with cataract, but they're also identifying people with presbyopia, the confidence in that household that somebody knows what they're doing because they fix somebody's near vision issue increases the likelihood of someone with cataract taking up services. The other side of the equation is people who've had cataract services, many of them will need a pair of near vision glasses to optimize their cataract outcome. So although they are separate diseases, if you like, they are very intrinsically linked in terms of their management. And the final thing I'd like to say is just something that Oteri shared with me in Nigeria a couple of years ago, which came from field learning around near vision glasses being a safety issue. And you did mention this, that when training primary healthcare workers around this, they realized that they did not know they had a near vision issue and were delivering vaccinations unable to read the vials. This changed the temperature on this issue, and it stopped being a presbyopia eye care sector issue to a safety issue around vaccination. And so we ought to look at what are the opportunities within our small sector to elevate this into a bigger issue. And so with that, I'm going to go around the room and ask you to give your final 30-second comments before we close. Please unmic and go first, whoever's ready.
Okay, I'll just jump in. I just want to say that clear vision is very addictive. Once you have a pair of glasses, you are going to rely on it. For instance, I hardly can take off my glasses. So even as we develop solutions to scale access, we need to be able to think about outside the box to be able to open several channels for people to continue to have access to this to the spectacles. For instance, another thing we can do is integrate eye care, presbyopia screen and provision of glasses into school eye health programs. So when you go for the school eye health programs, you also attend to the teachers and all the other adults staff in the schools. So that's another pathway beyond, in addition to the community health workers, primary healthcare workers, addressing presbyopia at scale. And then we also need to strengthen, train, at least give some level of training to people at community pharmacies to be, we are testing something like that in Nigeria, and it's been very rewarding so far. Thank you.
Thanks, Oteri.
Yeah. I'll jump in next. I think I'm assuming that most of the people on this call are somewhere connected to eye care, probably as providers or program managers. So two things. One is make sure that every patient contact that comes to us, we sometimes are siloed, we pick up only cataracts and things like that, but then recognize that many would benefit from near vision correction. That would be one easy thing to do. And the next one is that in terms of captive audience and cost-effective intervention is to focus on workplaces, just like tea gardens, or factories, or so those areas where you have a captive audience, and then I think the intervention can be also very effective and with less effort.
Yeah, great. Thanks, Tulsi.
Thanks, Andrew. So my one would be very quick. I would just urge those to concentrate on. We have evidence-based protocols for near and distance vision screening and dispensing of reading glasses. I would urge those that are involved in programs to follow these protocols, implement these protocols. This is how we can alleviate some of the tension that Priya was talking about before and ensure quality and make sure that those with other eye diseases can be identified and referred appropriately within health settings. So thanks.
Thanks, Stuart. Final word to you, Priya.
So I would say that we need to move from a specialist-led approach to a very systems-level approach for presbyopia. If people need a specialist to get a simple pair of near vision glasses, then we're not protecting our profession. We're doing something really wrong. We're excluding those who could, solve their problem very quickly. So I think in your context, think about where you can actually get involved and make that change.
Great. Important final statement there, Priya. Thank you. And a huge thank you to everybody online listening, for everyone who participated, to the Livelihood Impact Fund, to the Community Eye Health Journal, International Centre for Eye Health, and all the amazing panelists. I'm sure if I could hear you, I'd be hearing cheering and applause right now. Lovely to have you with us today, and thank you for being with us. Bye for now.